Thank you very much, and thank you very much for the invitation. We all know the risk factors for post-thrombotic syndrome, and also one of the main problems is what the symptoms that the patient suffers as a result of PTS. If we look at the trials that have been presented today, the end game here, to me, should be the quality of life that the patient sustains after as an endpoint. Now, the 𝗚𝗏𝗃 score is perhaps a little bit subjective, but if you look at these studies, it showed that, in fact, there was no significant difference in the quality of life in these major studies. So what do these studies actually tell us? Well, just from the last speaker, we know that this is very much market-driven, very expensive equipment, and to some extent, the outcome is similar to conservative management, and the quality of life isn't necessarily improved. And we need to ask, does the patient actually fare better? Or perhaps controversially, are we jumping on the EVAR bandwagon? So I've been asked to talk about surgical thrombectomy. So I'm going to show you a few studies. Now, I accept that there's not large numbers in these studies, but it does show a trend of some sort. So the first one is Mühlberger, where 67 patients, quite a large number lost to follow-up, but he's looking at a primary patency at 88%, and no patients had severe PTS, but about just over half had mild to moderate symptoms. If you compare open thrombectomy with a fistula to maintain patency, the incidence of PTS was about in a fifth of the patients, and out of 48 patients, just over half had long-term follow-up with a primary patency of around 89%. But they did have impairment of the quality of life. If we look at early surgical thrombectomy, now this is quite a small study of 21 patients, but they were looking specifically at patients who had less than 10 days of symptoms, so they were early presentations. And the median follow-up at 6 years showed that 90% of the patients did not have PTS. If we compare surgical thrombectomy versus anticoagulation alone, we probably would accept that these results would be pretty obvious, that you've got higher iliac occlusion rates in the anticoagulation group versus the thrombectomy group. And so as a result, surgery was superior to anticoagulation alone. And what about early and late follow-up post-surgical thrombectomy? Again, small number of patients, 57, and only 30 available for long-term follow-up. But these follow-up patients, they had 70% of them had patency, and around a quarter had PTS. But importantly, almost all the patients were satisfied with a good quality of life score. And venous thrombectomy for iliofemoral DVTs, a small proportion of these patients, about a quarter, had angioplasty and stenting with the thrombectomy, and none of the patients had severe PTS, and about a fifth had moderate PTS with a reasonable patency at 5 years. So the advantages of surgical thrombectomy is that you're actually moving a large amount of the thrombus load. You can supplement this with treating the underlying stenosis, and it's probably more suited to the younger patients, and by that I mean less than 55, so I just about fit into that category. And it's best treatment for really bad thrombus load, such as phlegmasia. it does have a better residual patency and a lower risk of bleeding. The disadvantages, of course, are that it is a surgical procedure which requires a theatre visit. We all know what happens when you open a groin. There's a pretty significant chance that there'll be a wound infection and dehiscence, and there is a poor outcome in late presentations with a relative contraindication in malignancy. And in my experience, I've always found that if you try to declot somebody who's got advanced malignancy, then they clot up very rapidly. And what about surgical bypass? Now, I do apologize, there's only 1 or 2 slides about this because we've actually gone away from this. Certainly in our unit, in the last 2 years, I can only remember one Palmer's procedure that was performed, and that was by one of my colleagues. And now the literature is really pretty much based on small series and case studies. And to some extent, this is superseded now by wire recanalization and venous stenting at the same time that you carry out your surgical thrombectomy. And importantly, when you do this non-invasively with wire recanalization, you don't upset the venous collaterals, which are quite important in these patients. So this is the type of venous bypass, and there's not really high-grade evidence to suggest that even a fistula is necessary in these bypasses, whether it makes a significant difference. So in conclusion, the outcome data for thrombectomy devices doesn't necessarily improve quality of life. They give you amazing images. And surgical thrombectomy, I would argue, is still a viable option for certain groups of patients. And as most of the speakers have said, your outcome is going to be tailored depending on your patient selection and how they present. Thank you very much.